Doing these things.
Hello everyone, thank you very much Integrated Care Partnership for talking to me today. Really nice to hear. I'm looking forward to hearing about your work with long-term conditions, particularly management of heart failure patients. Thank you Dr Farnsworth, thank you Nicki, and thank you Dr Jones from Integrated Care Partnership. If you could just talk to me today and tell me a little bit about what you've been doing.
So we ran a winter project last year, managing and supporting patients with severe frailty and heart failure, looking to put some input in to keep them well and at home.
Yeah, so the idea really was we were aware that a lot of our patients were going in and coming out of hospital frequently throughout the year, those with severe heart failure and frailty in particular. And what we looked at was to see if we could put something together such that we could prevent this rolling door essentially of patients decompensating with heart failure, improving and then going back in and over and over again. We looked at a sort of cohort of patients who had had more frequent admissions. I think it was 5+ admissions over the previous year.
Right.
What we then did was to do a clinical assessment with Nicki as a baseline, and then if patients had access to a care coordinator, if they felt that their heart failure was decompensating during that time, we give them sort of a patient information leaflet with respect to what's called Pumping Marvellous, which is a national charity for patients to be aware of what the signs were of decompensating heart failure, whether there would be more breathlessness, whether their weight was going up, or whether they get more ankle swelling. If that was the case, they could contact us directly then, and Nicki would go back out, or one of the team would go back out to reassess and to see if there was what we could do with regard to their baseline diuretics, to see whether we could increase that so that we could bring them back down to a baseline level such that they wouldn't be severely decompensated and then end up into the hospital.
Excellent.
Yeah, I suppose realizing how many of the patients that we share, and I guess I have the privilege of working across the Integrated Care Partnership, so across Surrey Downs Health and Care, where I have with my team or our team patients both in the physical hospital and the virtual hospital, but also have the privilege of working more proactively with the ICP. And so I think a real opportunity to me for us was to be able to work collectively to look after these patients wherever that was most suitable. So if that was in the patient's home, great. If that needed to be in physical hospital, we could still provide that continuity and ongoing, making it more personal for the patient, providing that continuity, and I guess more laterally with the virtual ward, an opportunity to give treatments that would otherwise only be available in hospital, like intravenous diuretics, etc., that we could then provide in that patient's home.
Oh, excellent.
And hopefully, provide treatment where it's most suitable. I think we're discussing this at some point, it is not algorithmic medicine. This is very much something that has to be tailored to the person, and it can be a little bit more of an art than a science at times, and to get it right, and having a forum where you can have a shared decision making, positive risk taking sometimes, or coming to a consensus to with the patient what's best, and I think that's a real privilege to be able to have that network.
You have regular MDTs, don't you?
Yeah, we have monthly MDTs, but that's for patients who we are looking after proactively. But we can engage with the community, the virtual ward team, and within the frailty team. If we are struggling with managing the patients, the frailty team will actually come out to see the patients. But we did, within the cohort of patients that we did look at 25 patients in total over the last year. We had sort of saw those through the period of time where the project was funded. There was a significant difference. The previous year, 22-23, the patients that we looked at had 160 bed days, and since doing this project, that has massively been reduced down to 60 bed days over the same period over the past in this year. So
that's a massive reduction in bed days, just from your small team working more collectively and integrated, isn't it?
But it doesn't take much. If you know your patients, you know the ones who are could be unstable, because heart failure patients by definition are unstable, and there's, you know, we know that they will deteriorate. You're not going to stop everybody going in, but you know, you highlight and try and hone in those patients that are, you know, will be more susceptible to going in and out and in and out. So by targeting those patients, you can make a lot of difference to the patient, not necessarily just the bed days. The patients don't want to be in hospital, they want to be at home, they want to be cared for at home, and I think it made a significant difference. You know, and looking after them holistically, we then had the opportunity to discuss other things such as respect, you know, because heart failure is a diagnosis which has worse mortalities than a lot of cancers, really. So you have those opportunities to think about, you are potentially coming towards the end of your life as well, and then ensuring that the end of life care of patients with heart failure, it has been addressed rather than a reactive, things are going wrong, we need to get in and do something now. So it gives those opportunities for those discussions to happen before it comes to a crisis point.
I think end of life care with heart failure is an area that's not always addressed. So knowing your patients and managing a good death at home is absolutely fantastic as well, isn't it? So yeah, that's excellent. Nicki, any other final thoughts?
I was just going to say, we used the comprehensive geriatric assessment, so all of the patients got a very holistic assessment of their care needs, and it's not just about the medication. It's about like looking at other aspects, like community alarm. Do they know who to call? Can they call? Have they got enough care? All those kind of aspects as well. So we don't just look at the medication, it's kind of looking at the wider issues that might be impacting on somebody, because sometimes that's what takes them into hospital, is the fact that you know, they haven't got enough care. So we did a lot of that kind of side of it as well.
And you also talked about the de-prescribing, being quite proactive about that as well. Do you want to just talk?
No, I was to say that the structure of the comprehensive geriatric assessment that Nicki was alluding to is something that is not just for this cohort of patient, but I don't know how many hundreds of patients have gone through your proactive frailty and disease, but it's a very systematic way of thinking about it. And it doesn't matter if you are a doctor, a nurse, a paramedic or a therapist, everyone now collects that information very much focusing on what matters most to the person, and then going through a systematic, comprehensive assessment, and that's then brought to a forum where we can support that personalised decision making. And de-prescribing is a big part of that, advanced care planning is a big part of that, optimisation of chronic health conditions is a part of that, social care becomes a part of that, emotional, functional support. So it's not just for this specific heart failure cohort of patients. It is also a forum by which we pick up a lot of unidentified heart failure, I would say. So a lot of particularly patients that might be older, that might have diastolic dysfunction, that might not have been identified, but actually when someone that comes in contact with a person is then reminded of that and feels enabled or given the permission, if you like, to bring a patient to a proactive forum, which isn't just the reactive crisis kind of response. It's a real good opportunity for, I guess, good patient care, I think, for shared decision making, for networking, for trust to build, and actually education. And I think that's been one of the strengths, and it's, it's perhaps not the sort of Amazon Prime approach of result right now, but it's the longer term result, I think, and certainly that's, I feel very privileged to have been able to work with the team in that sense.